Hello, I'm Megan Ryan, and I used to actually work with Dr. Gould in 2012, a long time ago, and it was a great experience. And I'm just going to tell you a little bit about her before she starts talking. So Madelyn Gould, MD, MPH, is the professor of epidemiology and psychiatry at Columbia University. She directs a research unit within the Division of Child and Adolescent Psychiatry at NIMH. Her outstanding research interests include the epidemiology of youth suicide, as well as the evaluation of youth suicide prevention interventions. During the past 3 decades, she has received continuous federal funding from the National Institute of Health, NIMH, Centers for Disease Control, CDC, and Substance Abuse and Mental Health Services Administration, SAMHSA, for her research in the area of suicide prevention. Her current projects focus on the evaluation of suicide prevention strategies, including telephone crisis services, chat services, continuity of care enhancements in EDs, and youth suicide screening programs. She is also studying suicide risks related to bullying, contagion, and modeling, and the effect of a peer suicide on fellow students. Okay, so I'm going to let you take it away.
Thank you. Hopefully you can all hear me. I just tried to share my screen and it said that it was disabled, and I prepared a lot of slides, so I would like you to be able to see them. So I'm hoping that someone will turn my capability on for sharing those slides. I just am so delighted to be here in real time. I'm sorry I couldn't be there in person. The disadvantage of not being there in person is that I cannot see you, and I don't know if you can hear me. Oh, good. I just got a note that said I am the host now, and so I can share my screen. Good. And I will share it. Okay, that's great. And let me now start the slideshow. Okay, so I am going to hope, unless someone can send me a chat to the contrary, that you see my slides. And I really am delighted to be sharing this information on the role of suicide crisis centers in the US, and really some new procedures and new policies that are being implemented in the US that I hope is a useful model for you all in Guyana. So what I'm going to be describing today is efforts to create a comprehensive crisis response system in the United States. So I'll be describing those efforts in the first few slides, and then most of my talk will be presenting the evidence of the effectiveness of the crisis hotlines, specifically the National Suicide Prevention Lifeline in the US. So I'll start with describing 2 very, very useful reports that are available online. And that one is, and this is, based in the US, but you can get these online. The National Action Alliance for Suicide Prevention's Crisis Now report and SAMHSA's National Guidelines for Behavioral Health Crisis report present models of an integrated crisis care system. And the aims of this system are to divert individuals in mental health crisis away from jails and emergency departments, to reduce unnecessary psychiatric hospitalizations, and to reduce law enforcement involvement in mental health crises, which does occur currently in the US. Obviously, the main goal of a comprehensive crisis response system is to get people who need mental health interventions the appropriate care, and to reduce their crises if possible in real time, and when they need further interventions, to connect them to care. But inappropriate interventions, as this slide is talking about, when they're sent to jail, and I think it's actually relevant to the earlier presentation, that's not inappropriate mental health intervention for someone in a suicidal crisis or a mental health crisis. And so I'll focus on the crisis now model, because I think it is, and it will be, the model of the future. It is the present in certain places in the US, but in terms of a model that Guyana may want to put in place, I think that this will be very useful. That it places crisis call centers at the hub of an integrated crisis care system, which also involves universal access to mobile crisis teams and crisis stabilization facilities. And I realize that some of these things may not be familiar to everybody in the audience. I've left plenty of time for questions so that I can, if there are any questions about, well, what is a mobile crisis team or what's a crisis stabilization facility, we can talk about it after the presentation. And according to the Crisis Now model, crisis call centers would be responsible not only for fielding calls, which they certainly do now, and de-escalating crises, which they do now, but they'd also be responsible for referring callers to additional services as needed. And they would also track and coordinate individuals' use of other services. And this role is described as a, quote, care traffic control, in the same way that there are traffic control responsibilities for people who are really taking responsibility for the safety of airplanes, that they don't lose sight of any individual airplane, that before they can even leave the room, they will hand off to somebody else. And in that way, someone who is calling a crisis center will always be in the hands of someone, that they won't fall through a safety crack, and that there will be continuity of care. So someone will call a crisis center. I'll be describing how crisis counselors can de-escalate a crisis. They can certainly refer callers to additional services as needed, but they're also now going to be tracking and coordinating the person's use of these other services and follow-up. And so this is about continuity of care for individuals who are in a suicidal or mental health crisis. And so I want to now describe what's happening right now in the United States with regard to a 3-digit number, a new national number for suicide prevention and mental health crisis response. There was an act, went into law, the National Suicide Hotline Designation Act of 2020, that designated 988 as our new national number, new hotline number. And that in July of this next summer, 2022, 988 will be activated nationally as the 3-digit dialing code for the National Suicide Prevention Lifeline. Currently in the United States, the Lifeline is reached by calling 1-800-273-TALK, which is 8255. And that the designation now of 988 as a new national number for these crises has propelled crisis centers, specifically those within the Lifeline network, really into the center of plans for an improved mental health and suicide crisis response in the US. I've been working in the area of evaluating crisis hotlines and the National Suicide Prevention Lifeline for nearly 20 years. And when I started, crisis hotlines were not at all in vogue. And I'll be describing how we went from people not even really respecting crisis lines in the US to where it is now with 988. So in a couple of slides from now, I'll describe how we got there. But before I do that, I want to first describe the National Suicide Prevention Lifeline. This slide was developed by John Draper, who's the executive director of the National Suicide Prevention Lifeline, and was kind enough so that I can share this with you. That the Lifeline is a network of independently operated, independently funded local and state call centers in the United States. It's not one large national call center. And as is highlighted in this slide, it's the national portal for connecting to localized services. So the Lifeline network currently consists of over 190 crisis centers across the US. In 2020, 2.4 million calls were received. And as I hope you can see, that someone now currently calls 1-800-273-TALK. They can press 1 if they're in the military or a veteran, and they would go to our Veterans Crisis Line. If they don't press 1 because they're not a veteran or in active duty, they would be routed to a local crisis center. And if that crisis center is busy, that it doesn't have the capacity to take that call, there are 9 national backups that will pick up that call. And so the Lifeline has enabled callers not to fall through the crack of just calling an individual local crisis center that may not, have the capacity to take all the calls at any given time. That by calling the National Suicide Prevention Lifeline number, you can get routed to a center, and if that center is busy, you'll get routed to another center. And that the Lifeline network also is it also has 30 crisis chat centers, 5 text centers, and this is going to expand within the next couple of years, 3 Spanish centers, and then a backup it is a backup for the Veterans Crisis Line. So hopefully this will give you some idea of what our National Suicide Prevention Lifeline is. And now I'll be specifically talking about the work that I've been doing to evaluate it. And I'll first describe sort of how we got from where we were in 2001, when we had our first national strategy for suicide prevention in the United States. And when that was published, suicide crisis lines were noticeably absent. That crisis lines were first highlighted in 2012, in the 2012 National Strategy for Suicide Prevention, and they've continued their prominent position in the 2021 Surgeon General's call to action to implement the National Strategy for Suicide Prevention. At the time of the 2001 National Strategy, the evidence base for crisis lines effectiveness was considered insufficient to include them in the strategy. The major milestone in the advance of crisis lines in the US was the funding of the national network of local certified call centers by the Substance Abuse and Mental Health Services Administration, SAMHSA, in 2001. And so I'll now present the empirical evidence on the effectiveness of crisis lines in the US that emerged after the 2001 national strategy. The evaluation of the national network of crisis lines has been ongoing since the network's inception in 2001. And I actually feel quite honored that I've been leading that evaluation since that time. And the results from the evaluations have been used by SAMHSA and the Lifeline to shape best practice standards across the network. New practices in turn led to additional evaluation studies, and that in turn led to new Lifeline and SAMHSA practices. And so this iterative, what we've called this iterative process between evaluation and practice, and then in turn more evaluation and more practice, is really considered to be a gold standard in data-driven decision-making. And it really is essential in any, let's say, crisis lines that you do set up, or network of crisis centers that you do set up, to include funding for evaluation studies, because these evaluation studies can be used in real time to inform those practices, see what's effective, see what's not working. And if something's not working, it can be used to shape better programs and to change training and programs. And that's what this iterative process has been for the past 20 years. So I'm not going to go into any details about the individual studies or the methodologies of the studies. You can certainly ask me, questions about it. Instead, I want to present the major findings from the evaluations. That prior to the Lifeline evaluations, there was a pervasive impression that callers to crisis hotlines were not seriously suicidal individuals, and that even our earliest evaluations started to dispel what was essentially a myth by demonstrating that seriously suicidal individuals do reach out to telephone crisis services. That from our findings, we saw 8% of the callers were actually in the midst of an attempt when they called. 58% had made a prior attempt. So it's not the case that callers are not seriously suicidal individuals. I'm emphasizing that, and that's my first bullet, because way back in the early 2000s, that's what the prevailing view was. And that a major finding from our earliest evaluations was the demonstration that caller suicide risk was significantly reduced from the beginning to the end of the call. Another major finding was that counselors at Lifeline centers were more likely, compared to counselors at non-Lifeline centers, to inquire about current suicidal ideation, recent ideation, and past attempts, and that callers were more likely to experience reduced distress at Lifeline centers compared to other centers. And this was it was published in 2017 by Rajiv Ramchand. What this shows is that the standardization of training that Lifeline centers have really has made a difference. Again, I'm going through a summary of the major findings, and then for those of you who are interested in the methodologies, we can discuss that after the presentation. So I'm now going to move into the area of callers who are at imminent risk of suicide when they call. Because, clearly there are all different levels of suicide risk, and that, there are, many, many callers who are calling for mental health crises that don't involve suicide at all. Clearly, determining whether a caller is at imminent risk of engaging in suicidal behavior and in need of emergency intervention is one of the most significant judgments that a Lifeline Crisis Center counselor has to make. And clearly, this is a judgment that frontline clinicians and first responders need to make as well. And that the Lifeline's imminent risk policy provides a formulation of imminent risk that's based on the core concepts of what was developed by Thomas Joyner and is called the interpersonal psychological theory of suicide. And that model combines suicidal ideation, which in the model is called suicidal desire, with both intent and acquired capability in assessing and evaluating if a caller is at imminent risk. And conversely, it asserts that suicidal ideation, which is actually relatively common, does not signal imminent risk of suicide if either intent or capability is absent. But counselors still use their clinical judgment and their training to determine if someone is at imminent risk. And they also examine whether callers have deterrence and buffers in their lives and social supports that might mitigate the risk. And so that's in their consideration as well. I go into all that detail because I think we all recognize that making the decision of whether someone is at imminent risk is is clearly a very, very difficult decision. And that what we've also seen crisis counselors considering, or the factors that they've taken into consideration to is, with regard to evaluating if a caller is at imminent risk, is whether or not the caller believes that they can keep themselves safe after the call, whether or not the caller is intoxicated, and whether or not the counselor can engage the counselor in collaborative problem solving. Again, I wanted to discuss the results of our evaluations. But again, if there are questions about what goes into the intervention and the training that crisis counselors have, I'm happy to have that discussion after the presentation. Now, with regard to this slide, because I am getting to the results on this slide and on this next slide, the purpose of our evaluation was not to assess the contribution of this, as I mentioned, the IPTS based components of risk. We weren't evaluating if someone was at imminent risk or not. We were using the counselor's judgment of whether someone was at imminent risk. What we were evaluating, the main goal, was to describe the types of interventions that are implemented with Lifeline callers whom the counselors considered to be, at imminent risk. As at the time that we did the evaluation, no one knew what, in a systematic way, what interventions were being used with callers at an imminent risk. And what we did find is that crisis counselors were able to secure the caller's collaboration on an intervention on over 75% of imminent risk calls. Now, there were times that emergency services had to be called. That's the police, the sheriff. EMS stands for emergency medical services. And in about 19% of imminent risk calls, the counselors sent emergency services with the collaboration of the callers. On another quarter of the imminent risk calls, the counselors sent emergency services without the callers' collaboration, because clearly there are times that the priority clearly is to keep the caller alive. I mean, it's always a priority, but sometimes you can't get the callers' collaboration if they're, intoxicated, or they already have a lethal means that they are not letting, that they're not willing to work with the counselor in a collaborative fashion to, to minimize the risk. That what we found also was that the collaborative interventions that don't involve emergency services, including, so this is now a collaborative intervention between the counselor and a caller who they deemed to be at imminent risk. They didn't call emergency services because what they worked with the caller in a collaborative fashion to do was to get rid of the lethal means or involve what's called a third party. This is someone who's in the caller's social network, could be a family member, it could be a friend, to get them involved in keeping the caller safe, to collaborate with the caller on a safety plan, and or to agree to receive follow-up from the crisis center. And that it's usually an and, that as if you look at the last bullet on this slide, we have other studies that have found that follow-up calls from the counselors to the suicidal individuals do reduce their perceived risk of future suicidal behavior. These were based on interviews, and when we then interviewed them after their follow-up calls, they gave, in terms of their own self-perceptions of safety and of reductions in their suicide risk, they would talk to us about how these follow-up calls did reduce that risk. So I want to emphasize that follow-up calls really is not a matter of only having a crisis center be the recipient of a call. What we've learned in the US is that they need the capability of also following up with callers to ensure that they are safe, that they have been linked with, supportive resources in the community, as well as, longer-term mental health resources. The middle bullet is a study that we did on third-party callers, because and these are folks who, again, as I was saying, are family members, friends. These are people who are calling the Lifeline when they're worried about someone else. And then that someone else is actually deemed to be at imminent risk when the third-party caller describes them to the counselor. And that because the National Suicide Prevention Lifeline, and I would hope that a similar service in Guyana would be geared to third-party callers who are worried about someone else. If someone's worried about their child or a parent or, a husband or a wife, a co-worker, and they don't know what to do about it, in the US, they can't call the Lifeline. And so we wanted to examine, well, what are the interventions that the Lifeline can do with third-party callers? And that we found that they are provided a range of interventions which can supplement and at times replace calling 911, which in the United States is our current emergency number. In the future, 988 will supplant 911 with regard to, mental health crises and suicidal crises if someone's thinking about suicide. If someone is already engaged in suicidal behavior, then a third party in the US will still call 911. But when you do call 911 in the United States right now, you get emergency services. And at times that does involve, the police as well. And that's what 988 is trying to replace, when appropriate. And so our study was very important in showing that there are other interventions that even can be used with a third-party caller. So they're calling about somebody else, not about themselves. And some of the interventions, the most common non-emergency intervention was helping the third party to contact mobile outreach, which involves, mental health professionals going to the house to do another assessment, or encouraging the, working with the third party so that that person knows how to talk to the person at risk so that they can contact the Lifeline, providing the third party with local, resources, including, mental health clinics and emergency departments. Or the Lifeline may contact the person at, at risk. They can also have the third party, has agreed to maintain a watch on, the person at risk, or speak with the person at risk, escort the person at risk to the hospital, collaborate with, as I was mentioning, mobile outreach, remove access to lethal means, encourage the person at risk to contact the Lifeline. So I give all these details because I, want to give the audience the information that there are many interventions that the Lifeline will use in a collaborative fashion, again, to help third-party callers help the folks that they're worrying about who are not going to call on their own behalf. That there are, individuals, I'm sure we all know of situations where folks in a suicidal crisis may be reluctant to get help for themselves, and that it really behooves the people in their social network to try to help them. And in this case, they can get that help by calling the Lifeline. I'm now going to move into the area of chat. The Lifeline is really first expanding its text-based services so that we focused our evaluation on chat services or online services, and that these were implemented to increase access to crisis services. And now the Lifeline Crisis Chat, which serves all ages, has grown extensively since its formal establishment in 2013. And in 2020, it answered, over 200,000 chats. But clearly, the capacity is going to be expanded because, as you'll see by some of our findings, especially for younger people, that they do prefer to use chat and text, and that we're also involved in an evaluation of the crisis text line in the United States, and that in the midst of writing up those results too. But I wanted to present the findings that have already been published, and that's with the Lifeline. So what we first found was that 84% of an LCC, stands for Lifeline Crisis Chat, that chatters endorsed either current or recent suicidal ideation, and this was on a pre-chat survey, which is markedly higher than the estimated 23% of Lifeline callers who we, have estimated to be suicidal on the day or the day before their calls. So as I said earlier in the presentation, that there are many, many callers to the Lifeline who are in a mental health crisis, but not necessarily suicidal. And our estimates are that approximately a quarter of callers are suicidal and can be seriously suicidal. And that, we're talking about hundreds of thousands of people given the volume of calls to the Lifeline, to the, a couple of hundreds of thousands of suicidal callers. But that's 23% of callers, whereas chatters, it's 84%. So clearly, more suicidal folks, are reaching out, or the chat, among people who chat, a much higher proportion of them are suicidal. And I'm now just going to skip to the, at least the main findings. We have the last slide of my presentation lists the, the citations, and I'm happy to share, a PDF of all of these slides, so that if you're interested in the details of the studies, you'll be able to look at them, on your own as well. So 2/3 of chatters reported that chat was helpful and that they were significantly and substantially less distressed at the beginning of the chat intervention than they were at the beginning. And about half reported being less suicidal at the end of the chat. Now, people have, when we had submitted the paper and published the paper, will say, oh, gee, well, that means half are not reporting that they're less suicidal. But when you actually compare that, a 50% finding, to other very involved interventions, they're comparable or better. And this is, based on, one chat. So, now this doesn't say that it, quote, cures someone forever. I've already said you need follow-up. They need to be linked to services, that the Lifeline is meant as a crisis response. It's not treatment. I'm not talking about online treatment or, treatment via the telephone. This is a crisis response. And half chatters, by the end of the chat, right, they're safer, they're less suicidal. So I'm going to now repeat, at least I need things repeated quite a bit to get them into my memory. And so I'm just going to give a summary of the Lifeline evaluations, over the course of these 20 years, that individuals at risk of suicide do utilize suicide hotlines. Clearly, there are some individuals at risk of suicide who do not utilize suicide hotlines. So, we want to hopefully maybe 988 will make it, more accessible. But at least we wanted to know of those folks who are utilizing hotlines, do they work? And that we saw, and now a number of findings, papers, that callers experience reductions in their crisis and suicidal states over the course of the crisis call. Crisis counselors can collaborate with callers to de-escalate imminent suicide risk without the use of 911 or an emergency department. Clearly, sometimes they need emergency services, but they can collaborate to de-escalate, actually over half of the, of imminent risk, over half of the, half of the imminent risk calls, about 60%. Now, callers may experience continued or recurrent suicidal thoughts in the weeks following their crisis call. This was one of the findings in our earliest studies. And what that finding, and that's why I emphasize that iterative process, what SAMHSA and Lifeline did when we had said, when we interview them weeks after, there are these, recurring suicidal thoughts or continued suicidal thoughts. And then they funded an initiative to include follow-up as an intervention to enhance continuity of care. And then what we found is that the follow-up calls were effective and are an important suicide prevention tool. And again, I want to highlight that follow-up calls should now and are now be considered best practice for, for crisis hotlines. And we also saw that crisis chat services are utilized by, I didn't go into all the details of the characteristics of the population, but they are utilized by a young and high risk population, younger and at higher risk than callers. And so they're important adjuncts to telephone hotlines. And that Lifeline centers have been shown to be more effective than centers outside the network. But there are still, challenges to the implementation of 988. These have been identified by our Lifeline evaluations. Clearly, a key challenge is also having enough resources to expand the services and to increase the number of counselors and have the systems. We have 50 individual states that are now gearing up for the implementation of 988 and working with SAMHSA and working with the Lifeline to ensure sort of a system in each of our local states that can work with their local mobile crisis teams and stabilization units. And what we though found specifically in our evaluations is that there's still room for improvement in communication between the Lifeline crisis centers, 911, EDs, and other crisis and emergency services. That currently mobile crisis teams and stabilization facilities are not universally available as resources for Lifeline crisis centers. So that is something that is currently being, addressed, but it's a key part of a comprehensive behavioral crisis care system, but it has to be developed. And that another key challenge is chatters and texters are more likely to be suicidal than callers, and Lifeline services, do need to increase capacity, as I was mentioning, to meet their needs, and also if there's a vast increase in the number of callers. And so I will end there. I do not expect you to even be able to see this, but I just wanted you to know that that I've listed these resources so that you can get more details about each of the evaluations that I've been referring to, and that I'm sure that I had it on my first slide, but I'm not sure you wrote it down, but I'm sure you'll be able to get my, email or ask, the wonderful folks who have organized this, the conference today, if you want to get, documents describing more about 988 and, now the comprehensive crisis services and, system, and it will really be a system that's currently being established in the United States. But from 2001, when crisis centers really were not regarded as a resource that, at least mental health professionals trusted, those folks who are working in crisis centers, felt that they were doing good work, and they were doing good work, but it hadn't been established yet. And so that by having now so many evaluation studies to show that suicidal callers risk can be decreased. So from 2001 to the first strategy that mentioned them, as I mentioned, in 2012, but that to now, to have them be like a central focus of the mental health crisis response system in the United States is really quite astounding and actually very satisfying to me as well. Okay, so I will now end my slideshow and stop the share. And I think, good. I see at least some folks. And as I mentioned, I left, hopefully if people have questions, this is the time. This is the time to ask. Thank you.
We have a question over here. I'm going to bring it over.
Hey, Madeline, I'm Lakshmi from India.
Hi. I can't see you, but I know your voice.
Stand in front of the camera. Okay.
Oh, now I see that. Oh, good. Well, I see the chair. Oh, good. I do. I see you.
Okay.
All right, great. Oh, that's so nice. This makes me feel like I'm there.
Yeah, that was a wonderful talk. And I completely empathize with what you said, because when I started Sneha in 1986, the professional said, "What are you doing? Why are you doing this?" And now there is a shift. But one thing I wanted to check with you is, in your slide, you said 1/4 of the time, the volunteers or the people the crisis line workers had to call the emergency services without the consent of the caller. How
Right.
was the response of the caller or the family when the emergency services arrived without the consent of the caller?
Right. Now that clearly varies, right? So that, and this is based on anecdotal evidence. The reason I say that is that in the studies that we've done, when we then asked the crisis centers what happened, right? We wanted to know what the communication or contact was between the caller, just the question that you asked, after emergency services was sent. And what we found out, which is why that last slide, and I didn't have another slide that said what future evaluation should be, very often the crisis centers didn't know what happened. They didn't even always know if they got to the emergency department, and they didn't always know, at least by the time we, were assessing what they knew, what that outcome was. So in future evaluations, what we're hoping to do, if we continue to get funded, is to follow up with callers for whom just the question you asked, for whom emergency services were sent with collaboration and without collaboration. So I say all that because what we do know is just from anecdotal reports from callers who, will call the Lifeline again, or we'll hear from other reports, or sometimes the counselors do know, or from people we actually work with who've had lived experience and have told us. So sometimes they are so grateful after they're stabilized, right? After their, mental health issues, social issues, because I totally agree with what you said, there needs to be a balance of taking, both into consideration. And that they look back and realize that they were very angry at the time, but they are so grateful, years later. And so that, but that's if they get linked to appropriate emergency services. What we've seen in the United States, right, these tragedies in the past, year and a half, and it had occurred much longer than that, but that became to light that emergency services are not all created equal. And if outreach is by individuals who are not trained to work with people in an emotional crisis, then we see tragedies, right? I mean, literally, people losing their lives, which is why mobile crisis services, which are, you'll have people in a car, going out, and they're trained. They may be social workers or, other mental health professionals, and they may be with law enforcement, but they work as a team to work in a non-threatening way. So if you get, you get that reaction, then, folks, even if they were dysregulated, totally out of control, but if someone knows how to work with them, as you know so well, they'll trust you and it won't escalate the situation. Unfortunately, in other situations, when it isn't with collaboration and someone comes by and tasers them, because we've heard reports of that too, where we've interviewed people and they said, I was really reluctant to tell a crisis counselor that I was suicidal. This was in some of our earlier work, because I was afraid that as soon as I said I was suicidal, they would call the police. And that had happened to them, where they got handcuffed and taken away. So, I mean, this is apropos of what you're saying as well, in your talk as well, when you get treated with dignity by someone who has mental health expertise is very different when you get treated as a criminal, so it's sort of a long-winded answer with not much specific data. Hopefully, in a couple of years, we'll have more data, but it has been a varied response. Yeah.
Yeah, I understand that, because we tried that in my center, and then we stepped away saying that unless somehow we gave more training to the volunteers to get the collaboration, because unlike the US, we don't have trained mobile crisis teams. So most of the time it is the police which will actually backfire. So it didn't work for us. The other question—
That wouldn't work. I agree. That's where now you have the crisis center, mobile crisis, and stabilization units, that you really do need that integration for it to work to everybody's advantage.
Yeah. The second question I had was, unless there are other people having questions, I'm not hogging we are planning to start a chat service, and from what majority of the chat service I found, that was if you're acutely suicidal, most of the chat services say please call the crisis line or go to the doctor or anything. But in your report, you say that most of them are, quite a high prevalence of suicidal ideation. So in terms of ethics and law, how do you handle that when the chat person we feel requires more mental health support, or for at least the telephone or something else?
So first I'll start with the fact that people do a chat intervention to begin with, or do an intervention via text, because I will fully admit that I first thought that was impossible. I thought this is, the same way that professionals who were used to, seeing someone in person said, well, you can't do something by the telephone because you don't have the clues. And the same way that, well, how do you do it via a text, or a chat? And now
I'm not saying how to do that.
No. So now I'm going to go on so that we've seen, and see if I've gotten your question. So we've seen that crises can de-escalate over the course of a chat, but clearly there are times that they don't. So I think this is what you're getting at. So what happens when they don't? That is when they will call, number one, they're all being supervised, but they'll try to encourage the person then to talk to somebody. And so that it's not as if using chat precludes also, having a telephone intervention. And then in the same way that it takes quite a bit of training, but in the same way that counselors dealing with callers then will connect them to mental health resources, that's what the chat counselors will do as well. So I don't think it's an ethical issue that's different for chat or text
Okay.
than for telephone. What I do think is that it does require, supervision, and that I didn't say, and I'm glad that you brought it up. We have a mix in the United States. Some centers use all volunteers, others use all mental health professionals, others use, a combination. And as you know, and I'm sure other people in the audience know as well, if you are using volunteers, even if they're very well trained, they still have to be supervised, right, carefully by, people with, really mental health training. And so I don't think it's an ethical issue any more with chat than with calls. But did I answer your question? Or
Yes, you did. Thank you very much.
Okay, sure.
Interesting. Thank you.
I do have a question.
Okay, you can speak, Holly.
Yes, it is. When I think about the telephone and persons calling on a hotline, I think about that cultural shift for Guyanese as such. And the question is, what do we need to do to have that cultural shift? Because making the phone call is not what persons with suicide do in Guyana. So what kind of infrastructure do we need to put in before
you even do that?
We get that 988 going?
Right. Well, obviously that is a huge, huge challenge. If I caught some of the prior presentation, and excuse me if I didn't catch all of it, decriminalizing suicide and suicidal behavior clearly is a first step, right? That, and I mean, there are just so many social issues. I think that part of what is needed is a lot of what would be called, psychoeducation with the general population, mental health literacy, so that at least family members will, and friends will become aware of what constitutes a mental health crisis, or suicidal crisis. I think teaching the population that suicide is preventable. I think that, for years and years and years, people just thought, well, suicide is not the result of, an undertreated mental health problem or a social problem that could be, resolved, and instead was this inevitable act. Now, if someone thinks something is inevitable, then they're not going to, to reach out, for help. So, but I don't think, I mean, there are many things that much more than, a few minutes can go into, but I did say, mental health literacy from an early age, right? I mean, right away in school, so that young people start to learn about mental health problems, life challenges in a way that they then are comfortable with. And it, may take a while, but I wouldn't wait until all of the population or all suicidal people are willing to call a hotline. If the service is available and it's confidential and people learn that, that somebody else was helped that way, then they may realize, oh, I could be helped that way too. So I think it has to be in tandem, that you clearly want to change these attitudes, but, that's going to take a while, but at least you want to give them an access, a means to start, receiving help. And one of the things that the crisis hotlines do was that they try to empower the caller to also find internal resources. There are different levels of risk. So clearly what you do with someone who's at imminent risk will be different than someone who's at, lesser risk. But knowing that there's someone who won't have a knee-jerk reaction to call the police, and is not afraid to listen to, as you talk about suicide, most people are scared, right, to even engage in that conversation. The crisis counselors, are trained to engage the caller, listen to them, have the caller trust them, and then once that engagement and trust is built, they can then start to shift the intervention to more collaborative problem solving. So I think that as vulnerable people learn that there's someone that they can reach out to who isn't going to immediately, do something that, as we were just talking about, sometimes there are emergency services, but changing the attitudes of a culture, that's, probably better answered, by sociologists and, and so on. And, folks like, Christina Hoven, who has, awareness programs in schools, and that these other mental health, first aid as a program and increases mental health literacy, people have to learn and in a young age about it. So hopefully that's at least one strategy.
Thank you very much.
Any other questions? Okay, so I guess if we don't have any other questions, that's it. Thank you so much to
Thank
Dr.
you.
Gould.
Thank you.
Thank
Okay.
you. Bye.
Bye.